Welcome, everyone, to the 27th Degree with Chris and Nancy, brought to you by 27 Degrees Consulting. We're excited today to continue our discussions on medical issues. Today, we have Dr. Ibrahim Eid with us, who is a vascular surgeon. We're going to talk a lot about vascular health and vascular disease. But before we get going, I want to recognize our sponsor, Varicose Bank. Varicose Bank is just right for all of your financial needs. Visit varicosebank.com or call 508-678-7641 to learn more. Now, before we go on and get into this, Nancy has some really exciting things to talk about just for a second or two, but we want to let our audience know this. So, Nancy, go ahead.
I love the way you limit me.
Just for a second
Just
or
for
two.
a second or two. So yes, the exciting news is that we've expanded our platform. You can listen to us on Spotify, on iTunes. You can go home and say, "Hey Alexa, play the 27th Degree with Chris and Nancy." And also, we're going to have coming up the ability to become Patreon subscribers, and that will give you access to exclusive content, sneak previews to our shows, and also some online chats with us.
Yeah, so this is really exciting stuff.
Yes.
So more to follow on that.
More to
But
follow.
We're really trying to bring more value to our viewers. So we hope this will be something that many of you will enjoy. So
now we're going to shift the focus to Dr. E. Hi.
Good morning.
So why don't you start by telling us a little bit about yourself and what you do?
I first want to start by thanking you for having me here and thanking you for having this activity. This is unbelievable for myself and more important for our patients and for every citizen out there. So thank you.
you're welcome. Thanks for being here.
My background is vascular surgery, but before that, to become a vascular surgeon, you really have to be a general surgeon. So I'm trained in general surgery as well. And in my particular situation, I happen to have also liked primary care. So I did get boards in internal medicine before I went into surgery. So I have a pretty extensive background, and that fits well with being a vascular surgeon, because as we're going to talk about today, vascular surgery is a more comprehensive discipline of medicine than what meets the eye. And the message I'm going to hopefully end with for our viewers is that a vascular doctor is not a surgeon who's waiting for you with a knife. It's much more involved than this.
Great.
Dr. E, do you have a location right here in Fall River? Talk a little bit about that.
Well, I back in 2002, I started the Center for Vascular Diseases, which is part of Prima Care. And it's been blessed since then, and we grew. We currently have offices in Taunton and in Providence, but our main place in the primary care facility in 901 South Main is where we actually founded the first office-based interventional suite in the state. So there's many procedures that we can do now in the office instead of the hospital. And thanks to the advances in technology and electronics and devices, surgery has become less invasive, and we're now able to do pretty advanced surgical procedures in the office setting.
So that's really exciting. I mean, the fact that you were the first one in the state to do this, and I've been to your center, and it is really amazing. The technology that you have in an outpatient setting is really phenomenal. But before this existed, patients would have to go to the hospital for many procedures that they now can get done in your office. And with that, of course, there was increased cost. It's much less expensive to do it in the outpatient setting. So, you're really helping to reduce the cost of healthcare also, which is great.
Yes, I thank you for saying that. Absolutely, we're the first in the state. We built this in conjunction with my friend Dan Gorin in Cape Cod. We built them together, and we beat him with the construction by 2 weeks, so I can say I'm the first in the state. But we're not the first in the country, and that the safety and the concept validation has been already done across the country. So currently there's probably 3 or 4 sites in Massachusetts, and I think this model is growing. The nice thing about it is absolutely significant reduction in cost and significant increase in patient experience scores. When you go to a procedure in the hospital setting, your adrenaline is very high. You're anxious, you're scared, there's loss of privacy, loss of autonomy, you name it. In the office setting, it's like going home. You know the staff, you know the nurses, it's the same people. It's a very cozy environment. As a matter of fact, when we do these procedures in the office, and this has been published out there, we use much less sedation. So the patients have such a low level of anxiety that we don't need to give them as much sedation and medications to calm them down compared with the hospital. And that actually adds to the safety of the procedure and the positive experience with the patient. Obviously, it's on us to triage and screen what's the best place for you. So we still go to the hospitals extensively. There's a lot of procedures that cannot be done in the office, and you have to exert wisdom and common sense and be your patient's advocate when you make these decisions.
So, you brought up a lot of good points there, too. It's like, and Chris and I, we've worked in a lot of different offices. And when I was with you in your office, you had said that the hospitality and the girls, they really make you feel at ease, and they really do. So, I get anxious as a nurse when I have to go into the hospital or something. I feel myself like you just have that anxiety. But what's really nice about your office is everyone's so friendly. You
Yeah,
go in there and it's
great.
just like they automatically just put you at ease. And then, the staff you have in the angio suites, that's like phenomenal.
Yeah.
So I think that's super important. Can you talk just about, like, if someone's not familiar with the term vascular disease and vascular
Yeah.
health, like
Yeah,
what
talk
kind
to
of
us a little
things
bit
are
about
you
that.
talking about?
So, vascular as a specialty, we're talking about blood vessels. Now, there's broad categories here. One is the arteries, which are the vessels that take blood from your heart to the body. And the veins are the vessels that return the blood to your heart from everywhere in the body. We deal also with lymphatics, which have to do with fluid management, and the main problem we see with these is swelling of limbs, but this is a small percent of what we see. The arterial diseases are more sort of in the news because they lead to amputations, they lead to strokes, they lead to heart attacks, they lead to bleeding from aneurysms, etc. So this is pretty serious. On the vein side, we see DVTs, which is deep vein thrombosis, clots that form in your veins. It can also become life-threatening. We see clots in the lungs, which unfortunately can be pretty serious and dangerous. But we see a lot of ambulatory problems with what we call venous insufficiency, which is a disease we see in active, reasonably young people. And this can happen to somebody who's 25, has some bulging veins in their leg or swelling in the leg. They're perfectly healthy otherwise. They want to enjoy life, but every time they walk, every time they go to the gym, they're throbbing, they're hurting. So these are diseases that are often run in families, but they're pretty easy to treat. We get an ultrasound, we see where the problem is, and more often than not, we could fix it within half an hour with a small procedure that's, again, done in the office setting. So that's a broad definition.
Yeah, so tell us a little bit about, vein disease. That's pretty common. We'll start with that. Varicose veins, painful varicose veins. Sometimes they're not painful. Sometimes it's just more unsightly and patients want to have them fixed for that reason. Is it covered by insurance? What exactly do you do to try to fix that problem?
That's a very important question because the big answer is most of the times they're covered by insurance. And this is where I'm glad to be sort of on the air here because this is where, unfortunately, some physicians tend to be dismissive of this condition. So your venous disease is not going to kill you. You're not going to die from it. You're not going to lose your leg from it either. But it will make you miserable. So there's new terms now, quality of life, or how a condition affects your activities of daily living. And if you're young and healthy and you have to stop every now and then during your day to look at your leg or raise it up or massage it or whatever, this is a condition that we accept now as worthy of being treated. So yes, if the condition is affecting your quality of life, the insurance usually will cover the treatment. It is valid. Well-being now is considered part of health. It is not only life and death conditions that society said we're going to treat and pay for and cover. Society is saying now you deserve to live, and you deserve to live healthy and feeling good about yourself. And sometimes that includes your perception of body image,
Right.
of your appearance, etc.
But some of this is, like you say, more than just image. I mean, people do have discomfort and symptoms with it also. But even if it's just an image issue, certainly that's valid to have it corrected also. But there are symptoms that patients will have. Can you describe the symptoms that patients may have with venous disease?
Absolutely. Venous insufficiency is a disease of failure of the veins to do their job, which is to return the blood back to the heart. So it's a backup of blood.
And how
trying
does that
to-
happen? Tell our audience how that happens. Why do
There is-
why do the veins not work?
Well, there's two ways. One is previous clots or obstructions, and the other one is valve failure. So the veins return the blood passively. The heart, on the arterial side, the heart is a pump. With every heartbeat, it pumps. If you like horror movies, you open an artery, blood will spurt out with every heartbeat and would literally hit a wall. The veins are a low pressure system, and that's why we draw blood from the veins. You puncture a vein, it's going to drip blood. So if you're a vein in somebody's leg, your job is very difficult. You need to move blood upwards back to the heart. Us humans, we stand up, and that's tough. And there's no pump. So how will the vein do it? Two mechanisms. One is the calf and lower extremity pump function. So when we move our legs, the muscles contract, they squeeze the veins, and the blood is pushed out of the vein. But the veins come with valves inside of them, check valves. And the valves open to let the blood go up back to the heart. And if the blood wants to go back down with gravity, what's going to happen is the vein valves will shut and prevent it from going down. So the failure of the veins can be obstruction, previous clots that don't let the blood move, or incompetence, valves that are not working.
Yeah, that's an amazing point, because I think a lot of people don't understand that there are actually valves in these veins, and that they actually have an active role in preventing blood stagnation in the lower extremities and whatnot. So,
Absolutely. So, and this is familiar. We see this slightly more in women than men. Has to do with the hormonal changes throughout the life cycle, etc. But we see plenty of it in men. But that stagnation can cause problems. The first is a feeling of heaviness, throbbing. So if you feel your leg is gonna like burst, or it's heavy, or is throbbing when you walk or when you're active, this is something that potentially can be figured out and treated. The later stage, you could see veins getting dilated. You could see small veins and under the skin. We call them spider veins, and then they get bigger and they become varicose veins. And eventually, there is leakage of blood products and fluid from the veins because of that backup and high pressure. And that can cause irritation under the skin. And the next phase will be dermatitis. So you're going to be scratching, you're going to feel itching in your lower leg, typically on the inside of the leg. And as a result of that, the skin could thin down. And blood products that could leak outside the vein have iron in them, and they have a lot of chemicals, and that will irritate the skin. So you're going to have hyperpigmentation. So typically this leg will turn brownish, will have a dermatitis, it's going to itch, the skin will thin out. And the end stage is an ulcer, is an open sore. And these ulcers could sometimes take months to heal.
yeah, they can be very difficult to heal.
Absolutely. They're very, very frustrating.
Very challenging.
Yeah.
Seen that quite a bit. And
I had a question.
yeah, go ahead. I was thinking, I had a thought that was coming
just so
to me,
you're
but
not
that's
forgetting
okay.
about me back here.
No, go ahead.
So just continuing that line of thought with the varicose veins, what are we doing that isn't helping ourselves with the varicose veins?
Yeah,
I mean,
what are the
like,
risk factors? Like what causes them? That type of thing?
Yes, Chris.
Okay.
That's exactly what I meant.
All right, good. Just want to clarify that, Nancy.
No, I mean, are we doing stuff like, you had said earlier about eating right.
Sure.
If you have diabetes, that can complicate things. And if maybe you have a stagnant job that you're sitting behind a
Yeah,
computer,
what are the risk factors for our audience?
10 hours a day.
This is an excellent question. Now, the predisposition to it tends to be genetic and familiar and also hormonal. However, it is also behavioral. So we are a society of sedentary people. So keeping your legs down all day long without walking. Remember what I said, the two ways to empty the veins are the muscle function, to squeeze the veins and the blood out of the veins up, and the valves. So when you have a desk job and you're sitting all day long with your legs down, that's not helping. So being active is definitely important. Having support stockings if you have a sedentary job will help. And keeping some level of activity. You probably know more than me about modern offices now where we have desks where people work standing up. We recommend people walking every now and then when you're on a long car drive. We recommend that you stop your car every like 20 minutes or so, go for a walk around it, etc. So it is a lifestyle issue. Going to the gym, being active, walking, bicycle, swimming, any physical activity is protective and can either prevent you from having a problem or delay its occurrence or make it milder.
With the compression stockings, do you have to be fitted for those to work like as best as they can, or can you just go buy some off the shelf?
You could go either way. The idea of the compression stockings is the ones that work the best, and that's why they're not cheap, is they are what we call graduated compression stockings. So if you go buy an elastic stocking and you apply it, that will help, that it could make you feel better. But if you actually have severe symptoms, you want a graduated stocking. What I mean by that is the pressure at your foot is going to be a little bit higher than the pressure at your ankle. Your ankle pressure to be a little bit higher than the lower calf, which is a little bit higher than the upper calf,
Makes
etc.
sense. Yeah, so
because
pushes everything up.
exactly. So the idea is you want the stockings to push the fluids out of the leg. If it doesn't work well, if it's all the fibers are cut, if some patients unfortunately think they can modify them, they cut part of it, etc. It can do the opposite then, and you get what we call a tourniquet effect, and it could make things worse. So support stockings will help significantly. Knowing how to wear them is also important. So I tell all my patients, if you wake up in the morning and you have your coffee and lounge and work in your yard and then take your shower, then put your stockings on to go to work, that's not good. Within an hour or two, your legs have filled with the fluid they want to fill. The idea is you put your stockings on as soon as you leave the bed, because as soon as your legs are going to be below the rest of your body, they're going to start filling with fluids. So the stockings should be worn first thing in the morning before you do anything.
That makes sense.
At night is when your legs will empty the fluid because you're going to be flat. So I do recommend that before you put your stockings on, put your legs up if you can for maybe an hour, half an hour to empty as much fluid as possible with gravity. I tell people I talk to about it is stockings are very good to prevent your legs from filling with fluid, but they're not strong enough to cook the fluid out.
Oh, that's a good point.
Yeah.
Okay.
So you want to put them on before you have the swelling in the early morning.
It's a really good point.
Yeah. It's interesting. I mean, I think a lot of people out there think of varicose veins, and I guess venous disease is such a benign thing, but what we're hearing is that it really has a significant effect on quality of life. It's not just a cosmetic issue, and not that a cosmetic issue is not important, but it goes beyond that in many instances where it really does affect how we feel. People are uncomfortable, and then in the more extreme cases, there can actually be skin breakdown and ulceration. So it really can be a serious condition, it sounds like.
Absolutely. And while it's not a fatal or majorly massive condition to have, but it does affect the quality of life in disease in people, and this is associated with more depression, less performance at work, less enjoyment of life.
Sure.
There's actually some basic questionnaires related to not only patient experience, but basically predictive questionnaires that tell you which part of the population are going to cost society money using healthcare. And some of them are as simple as asking people, is there anything in your body that makes you unhappy when you do your daily things? So just people who answer some of these questions with yes tend to cost society more money, tend to use healthcare more often. So absolutely, venous disease has a major impact on quality of life and cost of care.
So we talked a little bit about prevention and risk factors. What do you do about it? Other than telling people to wear stockings, what do you do about people who have really bad venous disease that they're not responding to the typical things? What can you do as a surgeon?
Well, first we identify that you have enough symptoms where we could cross from let's talk prevention to let's talk surgical measures. We start with an ultrasound, which is a test that takes around 20 minutes. It is completely non-invasive. We put the ultrasound probe and we check all the veins in your leg, from the deep veins to the superficial veins. And if we can match your symptoms or the dilated veins to a superficial vein that is incompetent, we get rid of that vein for you. And when I was younger, we used to do this under anesthesia in the operating room. We called it vein stripping. Pretty gruesome procedure. You're going to make an incision in the groin, another incision at the knee or at the ankle, and you're going to pass this long wire and tie the vein off and take it out of the leg. That works very well, but now, luckily, we do it in the office. And instead of removing the vein, we go in with a catheter and we ablate the vein. That's the medical term, but the idea is we close the vein. And there's many ways to do it. You could use thermal ablation, which you basically cauterize it or burn it with a laser or with radio frequency. We now do ablation by closure. So we use a glue. We go in the vein and we put a catheter and we inject a glue throughout the length of the vein and we seal it shut. Believe it or not, it's the same glue they use to treat brain aneurysms and other parts of the body, so it's pretty benign. These are outpatient office procedures. They take literally 20 to 30 minutes, and you walk out of the office already feeling better. Word of caution, though, because they tend to be easy and minimally invasive, that does not mean they're 100% safe, and that doesn't mean that we don't see complications. So make sure when you go seek treatment for these to go to somebody who's board certified and who has significant experience with this disease, because while 95% of the times you're going to get away with the patient doing well despite the procedure not being done perfectly right, but you really want to make sure that if there's any complication or if you don't get the results you want, you're under the care of somebody who's a credible provider for this procedure.
I think that's why your place is so great, the Centers for Disease
Vascular Health.
Yes, thank you. I was mumbling. But you met all those high standards, and you had to meet a lot of high regulations. So I know that if I'm going there, then chances are I'm going to have the best outcome possible. Am I feeling, because I'm such a baby with procedures and stuff, if I go in and I have a varicose vein and you do your magic, am I walking out of there with a smile, or am I like, oh, this hurts?
95% of people will walk out with a big smile.
Okay, good.
Maybe 3 to 4% will not, but they will walk out knowing that we've identified if there is something that didn't go the way we wanted to go, and we are dealing with it by the highest standard of care and attention and care. So, like anything in healthcare, this is not important because it's minimally invasive. So we don't treat venous diseases as a second-class citizen disease because they don't kill people every day. We treat these diseases and the patients who have them with the same seriousness and feeling of responsibility we
great.
deal when we treat abdominal aneurysms or carotid disease or any other more scary condition.
You know, I remember a couple of years ago, there was this big move. There was popping up everywhere. Primary care doctors were doing, injections in varicose veins and all that, and it kind of went away from what I see. But it doesn't sound like that would be a great way to get your varicose veins dealt with. You're better off to go to a center where someone's really an expert in vein disease, I would think.
Well, we are board certified vascular surgeons. Obviously, I can't say that if you're not a board certified vascular surgeon, you don't know how to treat these diseases. Physicians can acquire skills, after training, and I don't believe society or the law forces you to have a certain board certification. It is a choice. As a patient, you have a choice, and if you want to say, I want my doctor to have a very rigorous, specialized training, I invite you to come to us, and every provider in our practice is board certified in vascular surgery, basically.
So besides varicose veins, what are the other top diseases that you're treating?
We treat DVTs, so to stay on the venous side, which is blood clots that occur in the deep veins. These typically happen in people who have clotting disorders or people who are hospitalized. We're designed to keep moving. So if you put me now in the hospital and I have a pneumonia or I have a big surgery, I could form a clot in my veins because I'm not moving. And if I do, that clot could be a problem. It can cause a lot of swelling in the leg, sometimes can become life-threatening, leg-threatening. These clots can climb up to the lung. That's what we call a PE, or pulmonary embolism. These are among the top causes of sudden death after surgery and after hospitalization. So we treat these by taking the clots out, by prescribing blood thinners, etc. So that's a big category of venous diseases we treat. But I would say that a big chunk of our practice is arterial diseases. And arterial diseases are divided really into two families. One is occlusive diseases, which is the most common, which is built up of plaque, atherosclerosis inside the vessels and all the problems it can cause to any organ that the vessel supplies. And the other one is aneurysmal diseases, which is the vessels, instead of being narrow, are actually dilated, and aneurysms are entities that can kill us because at a certain size, that blood vessel can rupture and we could suffer from a bad internal bleed that can be fatal. So these are diseases that are within our specialty, and we see a lot of these. We also, as vascular surgeons, that's the unfortunate part of our job, is we are the doctors other surgeons call when there's issues with bleeding. So sometimes we're asked to run to the operating room or to assess somebody for sudden bleeding, whether it's traumatic from a knife, from a gunshot wound, or sometimes it's incidental bleeding colleagues could get into when doing surgery on some organs. So we are always available to run to the hospital, and I use this to apologize from patients where I've canceled appointments or we've canceled surgeries, etc. We are called for emergencies in my specialty pretty often, and that disturbs our schedule big time. We don't like it, but we're proud to do what we have to do.
That's great.
Doctor, is it referral only? If I'm a patient, do I only see you if I get referred to you, or as a patient, can I just say, oh, I think it's time to go see you, and why would I make that decision in my own head? It's time that maybe I call you up and see if I can get in to be seen.
In general, it's a good idea to go through your primary care doctors for referrals. I never mind somebody walking in, and we in our practice, myself and my partners, Raj Patel and John Kittredge, we never turn anybody down. However, A primary care physician actually can know better what specialists you may need. So if you call your primary care doctor and you tell them my leg is hurting, and I just heard a podcast by this Dr. Eid and I like to go see him, well, your primary care doctor can examine you and tell you actually it's a bone problem or it's a joint
Right.
problem.
It could be
And
something completely different. Exactly.
Exactly. So in general, regardless of the contractual relation with some insurance plans that force you to go to the primary care physician, it is good practice. They know a lot. I know vascular diseases. Chris knows everything else. So he is better than me in analyzing whether I can help you
Yeah.
or not.
Sure.
And I'm basically don't mind seeing you, but he is better to tell you if I'm the right doctor for you or not.
Yeah.
Right, right. So then with all the patients that you do see, has there ever been a time where this patient came in and you're like, oh boy, this is going to be a complicated case, and then like you have that like it's a success story, and can you share one of those success stories with us that
Probably thousands of success
I know,
stories.
but like there's always like one or two that just like really stick with you, like it's just like, oh, you feel so good about
I
it.
love this question because it also pitches into being a patient advocate. So the answer is absolutely. And among the tools I use are the big academic centers with physicians who actually make all their career seeing very complicated cases. So there is a percent of conditions and surgeries that we elect not to offer in a community setting. And we feel blessed here because we are so close to the best centers in the world.
Right.
So I always tell my patients, you know what, for your condition, I like to do any operation where I can tag it with a statement that I'm going to offer you the highest level care wherever you go on the planet. If I cannot offer that, it is my duty as your physician to tell you this is an operation that Dr. X in Boston or in New York or wherever has much more experience than myself, and I'm going to refer you to him. So we do that, absolutely. And it's the responsibility of the physician not to think of a patient as an immediate income.
Right,
You are a human being, and I want to treat you like I treat my own family. And there are some things that I will tell you. I'm going to find you somebody who's more experienced, and we do that.
Right.
And complex aneurysms and diseases inside the head, inside the brain. There are a lot of exotic things, but it's our job to identify it and to inform you that this is something we don't do. But if you want a funny story, I'm going to mention one. When early in my career, when I came here, I had a patient who had a very difficult aneurysm. And he came to me with a huge file. He's been to the biggest and best centers in the literally country or in the Northeast, and he had fights with them. He just didn't like the people, And he came to me because he heard I'm Lebanese, and he's not Lebanese, but he for some reason loves Saint Charbel, who is a Lebanese saint. So he came to me and he told me, "Hey, like, do you know Saint Charbel?" I said, "Do I know Saint Charbel? My dad made him saint." He said, "What?" I told him, "Well, my dad was an assistant DA or something in the government when they did the investigation by the Vatican. To make a long story short, he signed off on some reports, having seen the body of that dead priest who became saint. So the guy said, I want you to do my aneurysm." And I reviewed his case and I told him, you will not survive. You really need to go back to Dr. So-and-so with whom you had a fight. And he said, I'm not going to go to him. He was mean. I said, if I have your aneurysm, I'll go to him, etc. To make a long story short, I made him sign all the legal things that saying I told him I'm not good at this, but he insisted, and he did absolutely great.
Really?
And I don't know how he did great, but he did.
Saint?
And
Maybe it was Saint
makes
Charbel.
makes you wonder. So this is a case that stuck to my mind because I remember telling him, it's better if we go to a parking lot and you start running and I'll shoot at you. But he insisted, and I realized it's something I trained to do. I know how to do this operation,
Right.
but I don't do it often, and this is why I advise him to go to a tertiary center, thank God he did very well.
Yeah, thankfully. So let's talk a little bit about carotid disease. We'll kind of start at the top and go down with the arterial issues. You see a lot of carotid artery disease, and,
Yes.
and just explain to our viewers, why is carotid artery disease really an issue?
Well, carotid disease, just to define it, is a buildup of plaque, of atherosclerosis in the carotid artery, which is the vessel that takes the blood from the chest up to the brain. So it's basically here in this area. And plaque tends to build up in some areas, and it likes splits in the blood vessels. So wherever a blood vessel splits into two, which happens here in the neck, plaque likes to grow. So, and pieces of that plaque can sometimes break and go up to the brain, and according to which blood vessel they're going to block, that part of the body will stop functioning, and this is what we call a stroke. So, carotid disease is responsible for around 30% of the strokes. So it's not all of them, not even half of them, but a significant portion. So if you have a plaque in your neck, depends on how bad it is, you're going to be at risk of a stroke, and that requires medicines, etc. But as it gets more narrow, it reaches a point where the surgery becomes justified. So if you take, let's say, 1,000 people with a plaque that's 80% closing the vessel, and you operate on them, you clean up the plaque and you remove it, and you take another 1,000, you just give them the medications. If the plaque is narrow to a certain extent, the 1,000 who will have the surgery will do better. So out of these, you're going to have less strokes than people who just take the pills. So surgery for carotid disease became established as an effective treatment as early as the 90s. And there was big trials that actually proved that. Now, with the modern times, we have now stenting as an ability. So in some situations, instead of doing the surgery, which remains the gold standard, it is becoming more appropriate sometimes to put the stent in. Now, studies have shown that when you go in from the groin to put a stent and compare this with the operation, the operation tends to be safer in a big chunk of patients. But now we have even a newer procedure where we put a stent in, but we actually make a small incision at the base of the neck, and instead of going from the groin, we go from the base of the neck, which is closer to the lesion. We put the stent, and this seems to be, in some cases, the best of both worlds. So the answer here is if you have carotid disease, you are at a higher risk to have a stroke than somebody who doesn't have it. Your first line of defense is medicines, changes in lifestyle, behavior modification, etc. For a more severe lesion or a lesion that has already caused you a small stroke or some symptoms, interventions become appropriate. The most common intervention remains the surgery to clean up the plaque and close the blood vessel, but more and more we're doing stents. So this surgery is a protective surgery. If you've had a stroke, it's not going to reverse it. So it's very important to know that if you have signs of a stroke, you just call 911. You don't go into denial thinking it's something else, because time is brain tissue. But the surgery is designed to make it less likely you're going to have a stroke.
How much occluded do you have to be before you become symptomatic? Like you talked about 80% occluded. If when do you definitely feel
the more narrow the vessel, the more likely you could have symptoms. And in general, if you have, let's say, a plaque in your neck that's, let's say, 80%, you're looking at around 3% stroke risk per year.
Okay.
So it's not terribly high,
Right.
but the surgery will actually cut it in half. Now, if you have symptoms, your risks are higher. So if you come to me and you tell me, Dr. Eid, I have plaque in my neck because Dr. Jonkas did an ultrasound and found it, and how likely am I going to get a stroke and do I need surgery? I'm going to tell you your risk of a stroke is somewhere in the 3% per year range. And if it's 80%, let's say, or more, I will tell you maybe we should talk about operating on you.
Okay.
If you come to me and tell me I have this narrowing in my neck that Dr. Jonkas discovered, but I lost vision in my eye 3 weeks ago, or
Right.
I got numb in my arm 3 weeks ago, which is a sign of a
Right.
stroke or a warning sign of a stroke, then I'm going to tell you, we need to talk about fixing it rather than just talk about it. And so if you have no symptoms, we usually talk about the surgery when you're in the 80% narrow range. If you have symptoms, it goes down to the 50% range. So if you have a 60% narrowing and you have symptoms, we would tend to say, let's think surgery.
Okay.
If you have no symptoms, we will start thinking surgery at the 80% or more.
Okay.
Now, again, time is an issue in some situations. If you tell me about your arm numbness that happened 3 weeks ago, I'm going to schedule the operation, let's say, and do it in 2 weeks. But if you tell me I lost my eyesight or my arm was numb this morning and I came to your office at 3 p.m., I'm going to put you in the hospital. Because when you have an event, when you have any warning sign of a stroke, the risk of the major stroke is the highest when we're close to the event. So, as a matter of fact, every day that passes, if you haven't had the stroke, you become safer. So, this is why we message to the public: if you have symptoms, warning sign of a stroke, weakness, can't speak, slurred speech, loss of vision, typically like a curtain blocking your eyesight. All of these are not signs to discuss with your wife or husband over coffee. These are signs where you call 911 and you go to the emergency room because time is a major issue.
Yeah, I think that's a really important point because I see this quite often. Patients will come in and they'll say a week ago this happened or 2 weeks. And as you mentioned, time is brain tissue. And if you're having a stroke, there are things that we can do to reverse the stroke findings if you get to an emergency room right away. Sometimes they reverse on their own and patients are lucky, and that's called a TIA. But sometimes they don't, and they sit at home, and then by the time they get to the emergency room, it's too late to do much about. So that's a really great point for anyone out there, because I see this not infrequently. If you're having any of those symptoms that Dr. Eid mentioned, just call 911 and go to the hospital. Don't sit around and don't wait for an appointment with your primary care doctor. Don't wait to have a discussion about it. Just get to the emergency room and it'll get sorted out.
Absolutely.
So if you've just had a big old party with yourself for the last 10 years, you're overweight, your diabetes kind of out of control, then all of a sudden you just say, I'm calling it, I'm going to be real good from now on. How much of this vascular disease is reversible?
First, I have to say you sound like my wife. She keeps telling me I need to lose weight, I need to eat better, I need to do all of
There
these
you go.
things. And I wish I'm doing a better job, but it is an ongoing thing. It means, unfortunately, in modern life, we are bombarded by what I call the bad choices. The bad food tastes good. Bad food actually is very cheap and is available.
Right.
And we all live a stressed out life. So the average American has 2 jobs, is worried about losing their health insurance, where to send their kids for school, etc.
They may be inactive, maybe they smoke.
Exactly. So I call it the series of bad choices, and it is difficult to live the healthy life. And this is now at the center of what we can do or how we can try to help you. Vascular diseases are diseases of the modern world. You're not going to find them in the African countries where malnutrition and lack of food is an issue, where people are all eating vegetables and grains and fruits. So we focus a lot on prevention. And I like to talk a little bit about it and how you could change your life, because we're also reshaping how we practice vascular surgery into vascular medicine, but more often now we're using the term vascular wellness.
Yes.
And because vascular disease is up there competing with cancer as the diseases that where you can affect it by eating more natural food, avoiding chemicals in how you live.
Right.
So number one is diet, and uh, the American diet is terrible. Is good for my business, but it's terrible for the people. So it is known that shifting more into plant-based diets, into lower fat diets, etc., will improve your outcome. And I like to always grab the opportunity when I when I meet a patient for the first time who has been identified as having plaque, whether in the leg causing them to cramp when they walk, or whether it's in the neck, putting them at the risk of stroke, etc. I will tell them that don't treat me like a surgeon who's waiting for your disease to build up so I can operate on you. I want to help you avoid reaching my operating room. So, and we're now in the process of putting together programs where when you're told you have vascular disease, you meet a dietitian,
Nice.
you meet a physical therapist. We make sure you have the right shoes so we can get you into walking. We need to look at more advanced medical pharmacologic prevention, like some medications now that are derived from like fish oil, etc., that have been proven to reduce events and improve the plaque. We go even further into using what we call gaming theories. Means we're looking at having programs in the next year at the Center for Vascular Diseases where we're going to tell the patient we're going to measure your performance. We're going to measure whether you succeeded in stopping the cigarette, whether you're walking more, whether you're eating better,
That's great.
and potentially link it to some competitiveness or awards or rewards or whatever you want to call it.
That would be great.
People have tried activities like this before, and they do result in behavior modification. So the key term now is behavior modification. How Chris and myself can actually have a patient and play that patient's behavior in terms of using the education, the fear of a bad outcome, the empowerment, where we want to move the patient from a passive victim attitude, where like, oh my God, I have plaque, into the I'm in control attitude. I want my patient to say, I have plaque. How dare it come to me? I'm going to make sure it doesn't grow. You know,
Right.
I want to freeze it. I want to make sure this plaque will never hurt me. So we want that patient to grab control of his or her destiny and say, no cigarettes as of now.
Right.
We will help them do that. If they need some medicine, if they need some group therapy, etc. We're going to tell them, don't eat the bad stuff. And after you eat, go for a walk.
Yeah.
And we're going to have them meet the physical therapist to teach you how to walk better. Believe it or not, at a certain age, we all get gait problems.
Sure.
We all have foot problems. Somebody said, why can't you walk? Well, if I walk half a mile, my bony spur in my foot starts hurting me. Well, okay, do you have the right shoes? So we want to go more into a comprehensive approach. We're actually trialing now a new software where I'm giving some high-risk patients the ability to text me all the time.
That's good.
So rather than call and wait for us to call back, etc., we're going to we're going to have an ability to actually, I have some patients on it now where they can simply send me a text. It's a HIPAA compliant platform where the patient can actually communicate with me. So we're building, I would say within the next year, I'm going to invite myself here and I'm going to tell you that these things we're talking about are now a
That'd
reality.
be great for like a show and tell podcast.
Yeah,
you know,
yeah,
that
absolutely.
would be so many people would be interested in that. Yeah, definitely.
No, I do believe we could make an impact on the community. Yeah.
This is really a disease, or I guess, a field where even more than other fields, there's so much preventable. If patients were to have the right lifestyle, not smoke, control their high blood pressure, eat right, exercise, all of that would make a huge difference. Of course, there's genetic factors which you can't really do much about, but it really does come down a lot to what the patient does, doesn't it?
I will tell you, big time, and the failure of society here is also overwhelming. And in putting together this Center for Vascular Wellness, we did some financial analysis, etc. And the bottom line is there is no reward for you and me to do the preventive. There is none. I can talk to a patient for as much time as I need to, and then my manager will tell me, you can't make a living like this. We have big practice to support, etc. If I operate on somebody, there's disproportionately more money allocated for end stage, late disease management. And that led hospitals in particular to divorce the interventions that pay money from the prevention that is not glamorous.
Right.
Means if you as a primary care physician, if we adjust your reward system in terms of encounters with patients to reward more education and behavior modification, etc., you should get the glory of prevention and the reward for prevention.
Right.
We don't do that.
No, we don't.
Okay, I get the credit for putting a stent in somebody.
Right.
But who's getting the credit to make this patient not need the
Be
stent?
preventative.
That's
So
right.
this is a problem. So at this point, the answer is you and me helping the patient to be a self-advocate. The patient has to grab their destiny in their own hands, say, I'm going to eat better, I'm going to walk, I'm going to exercise, I'm going to be the master of my own health.
You know, I've known Dr. Eid for over 20 years, and one of the things I always appreciated about him is he doesn't think just like a surgeon. He really does think like a primary care doctor, an internist, too. He thinks about this stuff. Not a lot of surgeons do think that way, so it's really great. I mean, one of the things I've always appreciated is that when I call you about a patient, you know, you're not hot to do surgery. You know, you'll look at the whole case and really come up with a plan that's best for the patient, which I think is really great. So I just want to get that out there, that I've always appreciated that. And I
Thank you.
appreciate our phone consultations and whatnot that we've had many times about patients. So
Thank you.
we don't have a lot of time left, but maybe you could just for a minute or two just mention about two of the other big things that you deal with: peripheral arterial disease, and I know it's not a lot of time, and aortic aneurysms, if you don't mind.
Yes, absolutely. Aortic aneurysms is easy because finally the societies have submitted a lot of studies to the government, and screening is recommended. They are a silent killer. If you have an abdominal aortic aneurysm, you need to know about it because at a certain size you need it operated on. Otherwise, you're going to be at risk of a fatal rupture. If you wait for it to rupture, 95% chance you're going to die. If you fix it electively, 3% chance you're going to die. So it's overwhelming. So if you're above 65, if you've ever smoked, and if you have any family history of aneurysms, you qualify to have a screening ultrasound to rule out an abdominal aneurysm. And this has no copay. It is 100% free. And we urge every citizen, if you've ever smoked, if you're older than 65, or if you have family history of aneurysms, to tell your doctor, screen me for an abdominal aneurysm. That's approved by Medicare. It's part of the Medicare package. So that covers aneurysms. We can fix them with minimally invasive methods now. So
And just a point, a lot of this coverage through Medicare, which is it's a great feature. It's covered best when you have it with your first Medicare visit. So, you know, when you go for that first Medicare visit, that's when, you know, as a primary care doctor, I'm going to talk to you about doing an ultrasound and some of these other tests. So just be aware of that. Bring it up to your doc when you go on Medicare. And, you know, if it's applicable for you to get a ultrasound, it can really be life-saving.
Absolutely, absolutely. It's the welcome to Medicare.
The welcome to
package.
Medicare package, exactly.
Absolutely. Now, peripheral arterial disease, very common, and I will tell you, if it's severe enough that you have pain at rest, pain if you're doing nothing, if your foot is red, if you have an ulcer that's not healing, a scab that's not healing, you need to see a vascular specialist because you're going to be at a high risk of an amputation. If you have cramps,
If you don't do anything about it.
if you don't do
Right,
anything.
right, right.
So if you have these, we call it critical limb ischemia. You need a surgical intervention, which many times we can do in the office. We could do with minimally invasive methods. You will need it, otherwise you're going to lose your leg. On the other hand, I'm going to turn into a patient advocate now. If you have the peripheral arterial disease and you can walk, and the disease manifests as cramps in your leg when you walk, do not let anybody put a stent in your leg or operate on you, because you're still at a stage where you can be helped by exercise, diet modification, smoking cessation, and a bunch of medications, the new wave that will prevent you from needing an operation. Once you put a stent in somebody, that needs maintenance, and 30% of the stents will need another intervention in the next year. So you do not want to jump into the I've had a procedure wagon, because you're going to be likely to need more procedures. Right. So except if you have the critical limb ischemia, you should not have the reflex of a quick fix, because the quick fix will lead to more surgeries and eventually could potentially accelerate your leg being at risk. So if you just cramp when you walk, this is where Chris will help you more than I will. You need to change your life and be active and eat healthy, etc.
Right, and there are medications, and exercise is a huge part of it. I had a patient recently who came in to see me who has known peripheral arterial disease, and he was really wanted to get a procedure because when he walked 18 holes, he had cramping, and you know, I told him, you don't need a procedure, keep walking. He went to a vascular surgeon who thankfully told him, you don't need a procedure, keep walking. He said exactly what you said. If I do this, you're going to be at risk for it closing up and having more procedures down the road. Just keep doing what you're doing.
Absolutely.
Yeah, great. This has been a wonderful conversation.
I loved it. Thank you for the opportunity, and I do believe how you put this together is a community service that's very valuable.
Yeah, thank you. I mean, I think there was a lot of really useful information that we got out there. And for our viewers, if there's anything that you are interested in and that you want to hear, let us know by Facebook or whatnot, and we will try to get that on the rolls for one of our talks. I want to once again recognize our sponsor, Varicose Bank, just right for all your financial needs. You can contact them through baycoastbank.com or call 508-678-7641, 508-678-7641. Why don't you give the number for your place, too, so people know how to reach you?
Well, we have this website, too, the Center for Vascular Diseases.com, and you could also reach us through the Prima website, and the phone number is 508-673-4329.
And we'll post that also.
Thank you.
So this has been great. Thank you very much. Nancy, is there anything you wanted to mention? How about our upcoming talk? What do we got coming up next?
So we have actually a fitness expert coming up.
Kind of ties into some of this a little bit.
Yes, and we also have a talk on bariatric surgery slotted in. So more to come on both of those.
Yeah, that's great. So we'll be back in 2 weeks for our next talk. Thank you, everyone, for listening to the 27th Degree with Chris and Nancy. And today, our guest, Dr. Eid. And we can't wait to talk to you again in 2 weeks with another topic.
I'd like to add actually one thing about Nancy.
Yes.
Nancy, a couple of years ago, came to my practice and reshaped it for us. And that was because we designed it where we never say no. So we have a huge number of patients who come to us. We don't triage, we accept all comers. And as a result, we've had issues with communication, with patient experience, etc. And what we learned from Nancy with that couple of months she spent with us was unbelievable. She lived with us, she analyzed every process, how we do things. And since then, we have improved unbelievably well.
That's great to
We're
hear.
not perfect, but we're definitely better, and this is a work in progress.
Thank
so we
you.
do appreciate it.
You know, we never talk about our business, but this is a big part of what we do. Other than the podcast, we do patient experience, process improvement. And one of these days, we'll actually do a podcast where we talk about those things.
Yeah.
Probably
yeah.
coming up over the next few months or so. But thank you for that input.
Thank you
We
very much.
appreciate it. Well, thank you, everyone, once again, and we'll see you again in 2 weeks.
Thank you.